So today I'm going to talk about another very important topic in internal medicine, that is peptic ulcer disease. Now, this is absolutely important from the exam point of view, as well as when you start working as a doctor, you'll handle a lot of cases of peptic ulcer disease. Now, peptic ulcer is a combination term for a gastric ulcer as well as a duodenal ulcer. This is a very common clinical problem all over the world. Okay. Male to female ratio is almost the same. There is no predilection for sex, and there are so many causes of peptic ulcer disease, but the two most common causes are Helicobacter pylori and NSAID use. That NSAID has to be used for a chronic time, for a long duration. Okay. If NSAID is used for a short duration, probably gastric erosion will occur, ulcer will not occur. But if it is used for a longer time, maybe continuously for more than few weeks, then it can lead to ulcer formation in the stomach or the duodenum. Now let's talk about pathophysiology. Now, how this ulceration occurs in stomach and first part of the duodenum. Now, peptic ulcers are defect in the gastric or duodenal mucosa. They are the defect in the gastric or duodenal mucosa which extend through the muscularis mucosa. Now you have to be very sure when you define it. What is the extension of that ulcer? Now remember, we are talking about mucosa here. So definitely it starts from the mucosa, but how deep it goes, okay? For the definition of ulcer, it has to reach through muscularis mucosa. If it is very superficial, we call it erosion. We don't call it ulcer. So muscularis mucosa is the important term there. So it extends through the muscularis mucosa. From the epithelium, then it is ulceration. When it occurs in gastric, means stomach or duodenum, we call it peptic ulcer. Now, the superficial portion of the stomach and duodenal mucosa exists in the gel layer. Okay, this is called mucus layer. Because of this mucus, acid and pepsin, which are the attacking forces present in that environment, cannot penetrate deeper. Means mucus layer is protective in that area. If acid and pepsin cannot go deeper, probably they cannot cause the damage. This is important knowledge. Now, prostaglandins, okay, of the type E, we call it PGE, PGE1 or PGE2, they have an important protective role to play because this prostaglandin, they increase the production of both bicarbonate and as well as the mucus layer. Now, the importance of mucus, I have just told you. Mucus will line, okay, that epithelium so that acid and pepsin cannot penetrate deeper. But what about bicarbonate? Bicarbonate will neutralize the acid. Bicarbonate is a type of alkali, so it will neutralize the acid. So prostaglandin is a very, very important compound there. Now, a little bit correlation with the treatment part. Okay. One of the drug which we give in the treatment of peptic ulcer disease is called misoprostol. Okay. It's a prostaglandin analog. And another important example I can give you here, why these NSAID cause peptic ulcer disease, because NSAID will block the synthesis of prostaglandin. Now the protection of prostaglandin is gone and there is a high chance of ulceration. Now under normal condition, okay, under normal condition, there is a good balance. Okay. Let me explain by underlying it. Under normal condition, there is a physiological or good balance exists between gastric acid secretion and gastroduodenal mucosal defense. Okay. This is a balance. Attacking forces versus protective forces, there is a good balance between them. Now, if attacking forces are more and protective forces are less, then there is a high chance of ulcer formation. Or if protective forces are far weaker than the attacking forces, then also same thing can happen. Now we should understand what are those attacking forces and what are those protective mechanism. Now mucosal injury, okay, mucosal injury and the peptic ulcer occur when the balance between the aggressive factor and the defensive mechanism is disrupted. That's what I told you just now. And these are the aggressive factors like NSAID, all those non-steroidal anti-inflammatory drugs, aspirin, diclofenac, ibuprofen, okay, indomethacin, all those different type of drugs. H. pylori infection, considered as an aggressive or attacking force. Alcohol consumption, bile salt. Okay, you may be wondering how bile salt reaches there. Okay, this is because of regurgitation. It can happen after certain type of stomach surgery, and during reconstruction, some of the bile salt may regurgitate up towards the stomach. Acid, hydrochloric acid, and pepsin. These are the major attacking forces which are present there. Okay. Now, what about the defensive mechanism? They include tight intercellular junction, tight intercellular junction of the epithelial cell. This is one of the important part of epithelium. Mucus, the mucus which is present on the surface. Good amount of blood flow, okay, good amount of blood flow in the mucosa, and the special property of mucosa or epithelium which is called renewal. For example, if some epithelial cells are damaged, then they can quickly regenerate back. So these are very important defensive mechanisms. Okay, let's move further. Now, let's talk about what is the role of Helicobacter pylori in the causation of peptic ulcer disease. Now, we all know this is one of the major attacking force, but what is the mechanism, how it causes the ulceration? Now, Helicobacter pylori is a type of bacteria which produces urease enzyme. It produces urease enzyme. Now, this urease enzyme, okay, will split urea. See that urease will split urea to form ammonia. Now that ammonia is an alkaline, okay, product, so it will alkalinize that microenvironment. Now we are talking about acidic environment in the stomach and first part of the duodenum. Okay, so if it is highly acidic, probably that Helicobacter pylori, okay, cannot survive if it doesn't have this type of property. But what it is doing here, it produces urease. It will change that environment into alkalinization, and then it will somehow neutralize, okay, that hostile property of acid so that it can survive there and cause mucosal inflammation. So this enzyme is very, very important in pathogenesis. Now another thing is happening here. The combination of increased gastric acid secretion and reduced duodenal bicarbonate secretion. In the first part of the duodenum, bicarbonate secretion doesn't occur that commonly. It lowers the pH in the duodenum. Now when the pH is low all the time, low means acidic pH, remember that. This promotes the development of gastric metaplasia, means the duodenal mucosa is almost looks like the gastric one. Now Helicobacter pylori, because of its special property of production of urease, can cause infection there, leading to duodenitis, and then after that it can lead to duodenal ulcer. So these are some of the important mechanisms. Now let's combine all the things which we have studied till now in this pathophysiology. In pathology discussion also, okay, you have seen this picture. Now see here, this is a normal thing. Let's talk about the normal thing first and then go to the abnormal one. Here are the damaging forces. Gastric acidity, okay, gastric acidity and peptic enzyme are also known as pepsin. These are the damaging forces or attacking forces. On the other hand, all of these are defensive forces. Now see this mucus. This mucus will not allow the acid to go deeper. Okay. Then bicarbonate secretion into the mucus. Prostaglandin has a very important role to play in both these situations, mucus secretion as well as bicarbonate secretion. Good amount of blood flow to the mucosa, this itself is a protective mechanism. So ischemia is an attacking type of force. Apical surface membrane transport, this is a normal mechanism of epithelium. Regenerative capacity and prostaglandins, these all are defensive forces. Now this is a normal thing, okay? There is a good balance occurring between them. Now see there, when injury occurs, if Helicobacter pylori infection is there, if the patient takes NSAID for a longer time like aspirin, if cigarette smoking is there, very important risk factor for ulceration, smoking. Alcohol equally damaging. Hyperacidity in that area, somehow if there is increased acid secretion, and when there is duodenal gastric reflux, that means when the bile is coming up from the second part of the duodenum towards the stomach, these all are injurious agent or damaging forces. Now at the same time, if we have impure defense like ischemia, we already listed the importance of blood flow there. If decreased blood flow, we call that ischemic condition. Shock, similar type of situation. Delayed gastric emptying means the gastric acid has a longer time to remain there, so it can damage, and certain host factors, so many other factors are responsible. Now all of these, what they are doing here, look here very carefully, okay? A good concept is given here. Look at this ulceration. Ulcer means loss of tissue from that local area, but how far it should extend. This is epithelium. Okay, after epithelium we have lamina propria, and the third layer is muscularis mucosa. So it has extended up to muscularis mucosa, or sometimes even beyond that. This is called ulcer, peptic ulcer disease. Now at the base of the ulcer there is always necrosis. We call it necrotic debris present. There are inflammatory cells. There is healing going on, which is known as granulation tissue, and when healing is completed, we call that fibrosis. So all these are important point in pathophysiology of peptic ulcer disease. Now, after going through all these important part, let's talk about what are the causes or etiology of peptic ulcer disease. Now see there. So many of them you already know. So just list them here, okay? Peptic ulcer disease may be due to any of the following. Helicobacter pylori, one of the major factors. Drugs, these are NSAID. And can you tell me one other drug which can commonly cause peptic ulcer disease? Yes? Who can answer me?
Sir, long-term use of aspirin can cause ulcer of the stomach.
Yes, long-term use of what? Which drug?
Aspirin, sir.
Okay, aspirin.
NSAID.
Good. Aspirin or NSAID is one, right? What is another drug? Any other you know? Any other?
So steroids.
Exactly, steroid. Okay, steroid. So remember these two drugs. Never forget these two examples, NSAID as well as corticosteroid. Both of them can lead to peptic ulcer disease. Now, smoking and alcohol are very important factors. Smoking and alcohol, we call them lifestyle factors. Both are equally damaging for our stomach. Severe physiological stress, like any stressful condition in our body, which may be there by burns, okay, head injury or central nervous system trauma, any major surgery, and any severe medical illness. All of them can cause excessive secretion of cortisol in the body, and that cortisol, okay, will cause a peptic ulcer disease. This is the correlation. There are two very important terms which are called Cushing ulcer and curling ulcer. Now, students already know this, I'm sure about it from the pathology discussion. Cushing ulcer is associated with ulceration in the stomach, okay, or peptic ulcer disease because of raised intracranial pressure or raised ICP. Now, how I remember this? Remember Cushing triad. Cushing triad occurs in raised ICP. That's why this is also known as Cushing ulcer. Now you will never forget this. Whereas curling ulcer occurs in the bones. This is a complication of bones or ulcer formation in the stomach as a result of bones. Okay, let's move on. Now, what are the other factors? Now, other etiological factors are Zollinger-Ellison syndrome. Zollinger-Ellison syndrome, which is a type of hypersecretory state. Now, fortunately, this is not very common. Zollinger-Ellison syndrome means there is a tumor in the pancreas. That tumor is known as gastrinoma, and it produces a lot of gastrin. Now, gastrin increases the secretion of hydrochloric acid, and then it can lead to ulceration. That is the relation. Physiological factors. Okay, some of the individual can produce large amount of acid. So that's why it is called physiological factor. Now see there, the basal, okay, acid output itself is increased in some of the individual. Now in them, there is higher chance of ulcer formation. Up to 1/3 of the people are like that. And another factor is there is accelerated gastric emptying. Now see there, in both this situation, what is happening? More acid is produced, and all that acid is going towards the first part of the duodenum. Now that acidification of the duodenum leads to gastric metaplasia. Now, we all know it is metaplasia, isn't it? The epithelium of the duodenum will change into the gastric-like epithelium. Now, when this happens, it will create an environment, okay, for colonization by Helicobacter pylori. Just now, few slides ago, I explained this point to you. Now it is repeated again here. First, the acid will go towards the duodenum. There occurs gastric metaplasia. In that situation, Helicobacter pylori can cause infection because it can produce urease enzyme, and then, okay, ulceration can easily happen. This is very important mechanism. Now, there are some genetic factors as well, okay, and those are 20% of the patient have a family history of duodenal ulceration. So it may run in the family. And one very important point which may be asked in the exam is blood type O people have, okay, have a chance of development of duodenal ulcer. Blood type O and duodenal ulcer, though there is weak association between them. Means all people with blood type O doesn't develop duodenal ulcer, but some of them can. These are some of the important points. Now, after going through all these things, let's talk about the clinical feature. Now, it is very easy for you to understand. Gastric and duodenal ulcer, okay, we cannot differentiate them based on history alone, but sometimes some of the features are quite characteristics. Like, let me tell you few here immediately. Epigastric pain, okay, can occur in both gastric and duodenal ulcer. But what is the relation of food regarding this pain? This is different between them. In gastric ulcer, the patient develops pain, okay, immediately after eating or even during eating. During eating or quickly after eating, the pain will be there. So as a result of this, okay, patient will not eat. Patient is afraid to eat because the pain is intolerable sometimes, isn't it? This is quite logical. If we have pain by doing something, we'll avoid doing that. So same type of things here. So the person will avoid eating and they may lose weight. This is one of the good association in gastric ulcer, weight loss and gastric ulcer. Whereas in duodenal ulcer, remember, it takes 2 to 3 hours afterward we have a meal, because that food and that acid should go distally and comes in contact with duodenum. Then only the pain occurs there, and that takes about 2 to 3 hours. So patient usually have pain after this much duration of the meal, and sometimes they have night pain, okay, and sometimes when they are very hungry they can have pain as well, which is called early morning pain. These are important point in duodenal ulcer. So the patient thinks, I am hungry, my stomach is empty, that's why I am having pain. So they tend to eat more food and they gain weight. So gastric ulcer patient may lose weight, they look lean and thin, and duodenal ulcer patient, they are overweight and obese usually. Though 100% of the cases are not like that, okay? But it is a good question to ask while you take the history. Now, another important point, duodenal ulcer pain often awakens the patient at night. I just mentioned this, and this occurs in almost 50 to 80% of the patient with duodenal ulcers. Whereas only 30 to 40% of the patient with gastric ulcer have this type of behavior. See here. Now, what do you mean by gastric outlet obstruction, GOO? In the short form, it is known as GOO, gastric outlet obstruction, or another term is pyloric stenosis as well. Now, this is one of the complications of peptic ulcer disease. Now, peptic ulcer disease is a chronic condition, and that chronic condition may heal with scar or formation or fibrosis or fibrous tissue formation. Okay. Now, if it is occurring very near to the pyloric sphincter at the region of the pyloric antrum, then that area can be obstructed, and this is called gastric outlet obstruction. Now, listen very carefully here. Probably you have studied in surgery, but I'm not sure whether you have studied or not. Now, when there is obstruction of the stomach, whatever content the stomach is carrying cannot go towards the duodenum, okay, and stomach will start to dilate. Now it will start to distend. The person will still eat, okay, and drink. All that food and fluid will be remaining in the stomach, and after some time the person starts to vomit because it's not going downwards. So vomiting is a very common feature of gastric outlet obstruction. Okay, now that vomitus usually have, okay, old type of food there. It has some sort of old type of food. Now, let me write few of the points here. This vomiting is a very, very important feature. So uh, old food may be there. Person may have eaten that food probably yesterday or day before yesterday. That food would also come out in the vomiting. Another important point, because of the repeated vomiting, okay, because of the repeated vomiting, there is loss of a lot of chloride ion. There is loss of a lot of chloride ion. Chloride ion in the vomitus. Now, if this process continues, then the person will suffer from metabolic alkalosis. Metabolic alkalosis. Now, this is one of the important complication of gastric outlet obstruction. Okay, so we call it, it has a particular name. We call it, okay, hypokalemic. Hypokalemic, because potassium is one of the important substance which is present in the acid. Hypokalemic, hypochloremic, the chloride ion is also lost. Metabolic alkalosis. This is one of the important question which may be asked in different clinical exams or MCQ. Hypokalemic, hypochloremic, metabolic alkalosis is an important complication of gastric outlet obstruction. Now, the loss of this potassium, okay, has another implication as well. Another reason may be there when we talk about kidney function. Now, what are the other symptoms of gastric ulcer or duodenal ulcer? Now, see here, dyspepsia is a very common feature. Now, this is a combination term for many other things together, like belching. Okay, belching means eruption of the gas outside. Bloating is a distension of the abdomen. Distension, similar type of thing, and fatty food intolerance. So all these combination term is called dyspepsia, and this is one of the very important early clinical feature of peptic ulcer disease. In a layman term, it is also known as indigestion. Many people call it indigestion. Oh, he is suffering from indigestion, but actually they want to, describe dyspepsia. Heartburn. Now, heartburn means this is a feature of gastroesophageal reflux disease. Now, as a result of excessive acid presence, okay, in the stomach, some of that acid may reflux up towards the esophagus. It is very common, especially if the person is obese, and this is known as heartburn. Okay, remember the term heartburn, another manifestation of gastroesophageal reflux disease. Now, hematomesis or melena can occur very commonly. Hematomesis and melena. Now, hematomesis is vomiting of blood. Okay. Now, what type of blood? This is important knowledge here. Now, the blood which is coming out from the stomach is altered because the blood comes in contact with hydrochloric acid, and it will convert that blood into acid hematine. Now, that acid hematine looks like a chocolate color or coffee color. Now, when the person vomit it out, it exactly looks like that. Okay, so this is a common feature of hematomesis. But one exception may be there. If the bleeding is heavy or very brisk, then even bright red blood can be vomited out. Whereas melena is black and tarry stool. Okay, black and tarry stool. Now, this black and tarry stool is also because of acid hematine. Now, it is going downwards and it will come out in the stool. There are certain important features of melena. One, it is very foul smelling. Second, it is dark, black in color, and this is very sticky. Okay, it's sticky, black in color, and very foul smelling. These are the features of melena. Now, rarely a brisk bleeding ulcer can present as hematochezia as well. Now, I'm sure you already know the meaning of hematochezia. Yes, I want to hear an answer here. What is hematochezia? Anyone?
So fresh
Red
blood.
color, red color blood, fresh blood in the stool.
Very good. Okay, all students know that. I'm sure about it. Passage of fresh blood in the stool is called hematochezia. Now, you may be wondering why melena sometimes and why hematochezia other time. So it depends how quickly or how briskly the ulcer is bleeding. in a heavy type of bleeding, hematochezia occurs because it doesn't have enough time for the alteration. That is the reason. Now, another one is anemia. Anemia is a very common feature because of bleeding. Now, there are two types of anemia which can occur here. In a chronic, okay, slow type of bleeding, always iron deficiency anemia occur, and that is uh, diagnosed according to peripheral smear by microcytic hypochromic appearance of RBC, microcytic hypochromic appearance. Whereas massive or heavy bleeding over a short duration can result in normocytic normochromic anemia. Never forget these two important, explanation. Microcytic hypochromic anemia is far more common than normocytic normochromic, even in peptic ulcer disease. Now, when the person is having anemia, all the signs and symptoms of anemia may be there, like easy fatigability or tiredness, looking pale, okay, and in case of severe anemia and chronic type of anemia, the person can have congestive cardiac failure as well. Now, sometime, okay, the ulcer may perforate. Now, perforation is considered probably the most severe complication of peptic ulcer disease. Now, let me take you a little bit backwards now. Remember till where the ulcer has reached in an uncomplicated situation. Only till the muscularis mucosa. We are still in mucosal region. Okay, so perforation means that ulcer is still going deeper into the submucosa, into the muscularis propria layer, and it has communicated into the peritoneal cavity. Okay, listen carefully. Now there is a very nice, communication between the stomach lumen or duodenal lumen and the peritoneal cavity. This is called through and through communication. It is called perforation. Now, what it is doing there? All the contents, okay, of the stomach and the duodenum may leak into the peritoneal cavity now. And we all know what are those contents. Acid. Acid is one of the main content. Pepsin, okay, pepsin enzyme, which is also present there. Food particle if the patient has eaten the food. So all of them will leak into the peritoneal cavity. Now we have major problem. In the beginning, these things will lead to chemical peritonitis because these are chemical substance, right, along with the food. So chemical peritonitis, but quickly that chemical peritonitis will convert into bacterial peritonitis, and patient will be very sick. This patient may die because of peritonitis, septicemia, and septic shock if not treated in time. And the treatment here is good resuscitation. The person is in shock, remember that, okay? So I need to give very good amount of IV fluid first. Confirm the diagnosis, then take the patient into the operation room, open the abdomen, which is called laparotomy, find out where is the place of perforation and patch it. This is called patching type of surgery. And after that, you need to clean that whole peritoneal cavity because it is contaminated with food particle. It is contaminated by acid. Probably some exudation is already there. So remove it, okay, and give a good wash. This is how the patient is treated in case of perforated peptic ulcer disease. And there is a high mortality if treatment is not provided in time. Now see here, okay, only 20 to 25% of patients with symptoms suggestive of peptic ulceration are found on investigation to have a peptic ulcer. That means that may be the first complication of peptic ulcer disease or first presentation. They never had any history of having peptic ulceration before or in the past. They may present in the hospital for the first time with perforation. This can happen. So we need to be careful with doctors. We are the one who diagnose this type of cases in the hospital. So the examination has to be proper. Okay, let's move on. Now, what are the alarming feature of this peptic ulcer disease? Alarming feature means that warrant the prompt gastroenterology referral, and they include the following: 1. Bleeding or anemia. 2nd, early satiety. 3rd, unexplained weight loss. 4th, there is progressive dysphagia or udinophagia, recurrent vomiting, and family history of GI cancer. Okay, so I'll explain all these things one after other. Now, bleeding or anemia is a very common thing to occur. I already told you that. Okay, so let's start. We are talking about the different alarming features in case of peptic ulcer disease. If these alarming features are present, then we should be urgent in our investigation and management. Now, if you are a house officer or medical officer who is working in some hospital or some rural area, now if you see these things, you should think about some complication and refer them to the consultant. That is the meaning. Now, what are these? Bleeding or anemia. Now, there are two types of anemia occurs: microcytic hypochromic and normocytic normochromic. It occurs on the rate of the bleeding. The bleeding is heavy, okay, within a short period of time. Then this is normocytic normochromic anemia, and if ongoing slow type of bleeding can result in iron deficiency anemia. Now, early satiety is a feature of carcinoma of the stomach, okay, and some of the features between carcinoma of the stomach and peptic ulcer disease in the beginning, okay, they are the same, like dyspepsia. Dyspeptic symptoms occur in carcinoma also. So we are not sure which type of disease we are talking about, but if the patient has early satiety feature, probably it is seen in linitis plastica or leather bottle type of carcinoma of stomach, because the lumen is already very small there. Unexplained weight loss, definitely a feature of malignancy, so we need to be careful. Early investigation and diagnosis has to be done. Progressive dysphagia or udinophagia, again the feature of malignancy. In case of stomach, probably this malignancy is present near the fundus area. Recurrent vomiting is a feature of gastric outlet obstruction or pyloric stenosis, one of the complications. It is also seen in carcinoma of stomach, and family history of GI cancer is a very important clue which is provided in the history. That means multiple cancers may be there inside the GI tract. Now, let's examine this patient, okay, from our side, that is physical exam. What are the findings? In uncomplicated peptic ulcer disease, the clinical findings are few and non-specific. Now, see here, what are those? They are epigastric tenderness, which is a mild one, and sometimes it is not present also. That's why it is written as non-specific. Now, sometimes even right upper quadrant tenderness may be there. Right upper quadrant tenderness may be present if duodenal ulcer is there, or more commonly it is in case of gallbladder or biliary etiology, which is one of the important differential diagnosis of peptic ulcer disease. Gallbladder etiology or disease or biliary etiology. Now, once important point I am going to tell you here, listen carefully. Some of the patient, okay, some of the patient, they keep on going to the hospital, and the doctor also keep on giving them antipeptic drug. The same thing happened with my mother, actually, my own mother. Okay, when I was studying MBBS, that time I was not with her, and she was suffering this problem. She had this abdominal pain, okay, near the epigastric area, all those typical symptoms. She used to go to hospital, and the doctor, he never did any endoscopy. He never did any ultrasound. All the time he used to ask where is the pain, and she used to show in the epigastric area, and he used to give the medicine, different type of medicine. Okay, now she didn't get better at all, and after a few months, already 2 to 3 months have gone. Then okay, uh, then she told this to me. I was not getting better. Then I just told her, maybe it can be a differential diagnosis there, isn't it? That's how when we are learning our medicine, our teacher used to teach us like that. Yes, you don't think about only one diagnosis. You may be wrong. You have to think some other also. So I just told her, just go and do an ultrasound, okay, and make sure there is no problem in gallbladder or biliary tract, pathway. And the same thing happened. Same thing came out in the ultrasound. It was a gallstone, cholelithiasis, and okay, one of the stone has already slipped from the gallbladder and gone into the biliary tract. Now see there, this should never happen. If your patient doesn't get better from your medicine, you need to ask question. Okay, fine, one time nothing happens, but multiple times same medicine or same group of medicine, the doctor was repeating, that is not good. You need to ask question, is my diagnosis correct? Is there any other disease in the patient? If that was the thinking, probably the disease was diagnosed long time ago. But fortunately operation was successful in her, okay, and she was all right. But this is just one example. I'm telling you, differential diagnosis are such an important point in case of medicine or medical field. Now another important aspect of physical exam is melena. Now this melena can be seen in the stool most of the time, but sometimes what can we do is we have to do per rectal examination, okay, and when we examine that finger which we have inserted inside the rectum, we can see black and tarry stool there. So this also gives us melena has occurred. Okay. Another point is succussion splash. Now succussion splash occurs because of gastric outlet obstruction. What do you mean by that? Succussion splash means ask the patient to lie down comfortably on the table or the bed, okay, go near to the patient and just shake the patient's abdomen, just shake it, and at the same time, okay, listen with a stethoscope. You can hear some splashing type of sound there. This is called succussion splash. This is because of the movement of the fluid inside the obstructed, okay, lumen of the stomach. Very, very important feature of gastric outlet obstruction. Now, patients with perforated peptic ulcer disease, when perforation has already occurred, okay, perforated peptic ulcer disease, PUD. Now, a lot more physical examination finding will be there. This patient usually present with severe and sharp abdominal pain, much severe than peptic ulcer disease. And when we examine this patient, all the features of peritonitis would be there. Now, you already know what are those. Okay. Unfortunately, the classes could not be taken, so I'm not sure whether you know these things or not. So please listen carefully here. In case of peritonitis, okay, when we examine, the whole anterior abdominal wall is very rigid, okay, very, very rigid. The muscles are in contracted state. I cannot put my finger inside at all. The muscle is board like rigid there. Number one point. Number two, there is generalized tenderness all over the anterior abdomen. Okay. Number three, there is presence of rebound tenderness also. Rebound tenderness means when I press in a particular area of the anterior abdominal wall, there will be pain. But when I take my finger away suddenly or take my hand away suddenly, the pain will be even more than before. This is called rebound tenderness. This occurs because of involvement of the parietal peritoneum, or you can say because of inflammation of parietal peritoneum. Now, when I press the parietal peritoneum, it will cause pain. But when I remove my hand, it will jump back in its original position it will cause even more pain. This is an important point. Now, another important point is bowel sound is absent in case of peritonitis. When you listen for the bowel sound, they are absent. Okay, and patient attains one typical position. Patient doesn't want to move at all, because if they move, there will be pain. So they just draw their leg upwards towards the abdomen. Okay, and it's like a cuddling position, also known as a fetal position. This is a very typical of peritonitis. Now, apart from them, this is a severe infection, so all the signs of infection may be there. Okay, like septic shock, tachycardia, hypotension, and even anuria. Now, kidney can also be already involved, resulting in anuria. This is because of hypotension and septic shock. So this is a very, very critical condition. Now, what are the differential diagnosis of peptic ulcer disease? Have a look there, please. There's a big list, isn't it? There is a big list. Now, it starts from non-ulcer dyspepsia or functional dyspepsia, which are not very serious condition, followed by some serious disorders. Crohn's disease is a type of inflammatory bowel disease. It can involve the whole GI tract from mouth to the anus. That's why it is considered as a differential diagnosis. Zollinger-Ellison syndrome can lead to repeated peptic ulceration in unusual areas of GI tract. That means beyond the first part of the duodenum, even in the second part, third part, fourth part, or even jejunum. So, and repeated ulceration. We'll talk about that a bit later. Cholangitis, okay, cholangitis can be there. This cholangitis is an inflammation of biliary duct. Okay, this is a ascending inflammation of biliary channel or biliary duct. Now, acute coronary syndrome. Okay, remember one important point I like to tell you all the time. In case of inferior wall MI, sometimes the patient may present with epigastric pain, and that epigastric pain may be easily confused with peptic ulcer disease. So many people, they have died because of delayed hospital management because of this problem. So we should be careful. Acute gastritis is very early situation. Okay, cholecystitis, just now I give you example of gallstone and cholecystitis, very, very important differential diagnosis. So ultrasonography will differentiate them. Chronic gastritis, till now ulceration has not formed, but it will soon develop into ulcer. Diverticulitis, Meckel diverticulum, or any other diverticulitis may be there. Rupture of esophagus and tear, different reasons are there. Okay, like Mallory-Weiss syndrome and Bohr-Haave syndrome, few of the name. Esophagitis as a result of GERD, gastroesophageal reflux disease. Gallstones, okay, the same GERD it is written here. This esophagitis may be caused by some other phenomena also, but most common is acid reflux. So it's a part of GERD. And even viral hepatitis, because the left lobe of the liver is present in the epigastric area. So if that is inflamed, you can easily confuse with peptic ulcer disease. So the list is extensive. So our mind should be open. We should always think, can it be something else or not? Okay, like that. Now, after doing this thing, let's talk about what are the investigation in peptic ulcer disease, how we confirm the diagnosis. Now, Helicobacter pylori is one of the main causative agent of peptic ulcer disease, so we need to prove it. Yes, this Helicobacter pylori is present inside the stomach or duodenum, and it is responsible for the peptic ulcer disease. Now, how we do that? See here. Testing for Helicobacter pylori, okay, testing for Helicobacter pylori is essential in all patients with peptic ulcer, which is the must. Now, how we do that? Endoscopic or invasive tests for Helicobacter pylori include a rapid urease test, histopathological exam, and culture, as well as fecal antigen test and antibody. Now see that if you list them one after other, you can give number here. Rapid urease test, number 1. Histopathology, number 2. Culture and sensitivity test, number 3. Fecal antigen test, number 4. And antibody test, number 5. Among them, okay, these days, the fecal antigen test is considered the most accurate and most commonly done. The fecal antigen test, the antigen of this particular bacteria can be analyzed in the fecal matter and it will give us the diagnosis. Now, rapid urease test is another one because this urease is the enzyme which is secreted by that particular bacteria. So we can utilize this principle. Okay. Even urea breath test can be done. Now, histopathology is done with the help of endoscopy, and culture can also be done with the help of endoscopic sample. Antibody, okay, antibody can also be examined, like IgG to Helicobacter pylori can be measured in the serum. So this is one of the very common question which is asked in the exam. Okay. Now, what's the role of endoscopy in this type of situation? Okay. Now, endoscopy is one of the most important investigation in peptic ulcer disease. There's no doubt about it. Now, we can ask different questions here to the students. What is the use of endoscopy in this case? We can answer in a different way. One is a diagnostic purpose and another is therapeutic purpose. Now, right now, we are talking about the diagnostic utility of endoscopy. Now, this is known as upper GI endoscopy. Another name for upper GI endoscopy is esophagoscope and gastroscope together. Now, it depends, right? These are different parts of the upper GI endoscopy. So, if you only use esophagoscope for the esophageal disease, okay, the same name is used, esophagoscopy. If I reach to the stomach, we call it gastroscopy. If I reach to the duodenum, the first part of the duodenum, duodenoscopy. Okay, so these are the different types of upper GI endoscope. It is highly sensitive for the diagnosis of gastric and duodenal ulcers. So this is an important type of investigation. This is highly sensitive because the doctor can see where is this ulcer. So the doctor can see it. They can take the picture of that ulcer, and at the same time they can also take the biopsy and cytological brushing from the ulcer. Now this biopsy can confirm what type of inflammation is going on there, isn't it? It can also rule out malignancy if you have suspected. At the same time, the Helicobacter pylori also can be confirmed, okay, by rapid urease test or histopathological test. Now these days, these rapid urease test kits are available, okay, so it can quickly done in the lab. Now at endoscopy, how the ulcer look? Okay, some of the student may be interested because later on, when they pass from this university, they can go to the different hospital. They can have a training of this ultrasound and endoscopy and all those things. So they should know how the ulcer looks under endoscopy. So see here, it looks like discrete mucosal lesion with a punched out smooth ulcer. And the base of the ulcer is usually have fibrinoid exudate. Okay, so this is how the ulcer looks in case of stomach. Now, whereas in duodenum, okay, they are usually solitary, a single, okay, and they are mainly seen in the first part of the duodenum. Now, still we're talking about the stomach ulcer here, which is the common site that I didn't tell you before. Which is the common site of stomach ulcer in the stomach? Now, stomach is a big area. It has so many different parts: fundic part, body, and antrum. These are three main areas. and the two sides, lesser curvature and greater curvature. Now this ulcer is found, look at very carefully, along the lesser curvature, okay, along the lesser curvature at the junction of the fundus with the body or body with the antrum. If you don't want to remember like that, you can remember only one point. It is very common along the lesser curvature of stomach. That is easy to remember, because whatever drink we have, whatever food we have, all that will flow distally through the lesser curvature. That's why it has high chance of ulcer development. The size of the gastric ulcer is not very big, probably 0.5 to 2.5 centimeter in diameter. Now, if it is a malignant ulcer, the size is big. Okay, let's go to another slide. Now, on the other hand, what is the size of the duodenal ulcer and how it looks? I already told you the first part of the duodenum is the site for duodenal ulcer. Okay, almost 95% of the time, only first part of the duodenum is affected. These are very small type of ulceration, less than 1 centimeter in diameter, and if we examine them, they are usually deeper. They are much deeper than gastric ulcer. That's why the chance of perforation is also higher in case of duodenal ulcer. So see there, duodenal ulcer, okay, they can extend into the muscularis propria of the duodenum easily. The muscularis propria means the outer muscle layer. That's why there is a high chance of perforation in duodenal ulcer. And one more thing, if it perforate, it can cause a lot of problem there. There is one important artery which is related with first part of the duodenum. This is known as gastroduodenal artery. That artery may be eroded by the perforation. It can result in massive hemorrhage in that area. And another one is peritonitis, of course. Now let's see some of the picture. Now see here, let me show you with a pointer. Now this is an endoscopic appearance. Okay, endoscopic appearance. See here, this is duodenal ulcer. This area is the ulcer. Okay, this area. This is not the ulcer. This is the opening of the pyloric sphincter. Now this is ulcer here, this area. And in this case, here is the ulcer. Okay, this is called exudate or fibrinous exudate at the base of the ulcer. Here is the ulcer. This is again the opening. Here is the ulcer. Okay, this area, and here is the ulcer. So ulcer looks like this under endoscopy. Now this is a magnified view of endoscopy. See here, the ulcer right here. This is the ulcer, very rounded one and looking like a punched out lesion, and this ulcer can perforate very easily. Okay, this is the opening of pyloric sphincter. Now, apart from endoscopic examination and Helicobacter pylori testing, another is radiological test, a radiography. Now, what type of radiological or radiographic test we like to do? Now, see here, in patient presenting acutely, means severe abdominal pain, they never have felt that type of pain before. They immediately know something is wrong here. Okay, that time if we take a chest X-ray, which includes both dome of the diaphragm, we can detect free abdominal air, and usually that air is collected below the dome of the diaphragm. Never forget this. Okay, it will collect, free abdominal air will be collected below the dome of diaphragm on the right side as well as on the left side. So we need to see very carefully. On the right side, it is very easy to see it. Just look at the shadow of the liver. Just focus your concentration above the liver and below the dome of the diaphragm on the right side. You will see thin strip of black shadow there. That is air collection, and this air coming from perforation of first part of the duodenum or stomach. So on the left side, sometimes it is a little bit difficult because usually there is gas in the fundus of the stomach, but still, because of the typical shape of this air, it is still easy for us to confirm. So remember, erect abdominal X-ray, or you can say chest X-ray, is the confirmatory investigation for gas under the diaphragm which occurs in perforation of peptic ulcer disease. Another type of radiological test we can do is a contrast study. Contrast study should be done with water soluble contrast. Okay, otherwise the very insoluble type of contrast, if it gone out, okay, into the peritoneal cavity, it can cause peritonitis. Okay, so that is the problem of this contrast study, and these are never the preferred type of investigation these days because we have got endoscopy. Sometimes even double contrast radiography can be done. Now, double contrast means we give air along with the contrast material. This is called double contrast, air with contrast material. Now, another type of investigation we like to do is angiography. Now, what is the role of angiography here? This angiographic investigation may be necessary in patient with a massive GI bleed in whom endoscopy cannot be performed. So bleeding is going on massively and you cannot do endoscopy because there is blood everywhere. Okay, I cannot see any field at all during that time. Which blood vessel has bled? Angiographic test can give you the idea. And there is one indication, an ongoing bleeding rate of 0.5 ml per minute or more is needed for the angiography to be able to accurately identify the bleeding source, because okay, that dye which we have injected when we do angiography should come out from the blood vessel, then in the X-ray it is seen. So at least the bleeding of 0.5 ml per minute should be there. Now another important part is the confirmation of Zollinger-Ellison syndrome. Now, how we confirm this particular diagnosis? By measuring serum gastrin level. And we all know serum gastrin level is high in case of Zollinger-Ellison syndrome because they are associated with a tumor which is called gastrinoma in the pancreas. That tumor will produce large amount of gastrin which is causing all the problem here. Now, what are the indications for measuring serum gastrin level, or in other words, what are the indications for the confirmation of Zollinger-Ellison syndrome? Now see here, patients with multiple ulcer. In peptic ulcer disease, usually the ulcer is present either in the stomach or in the first part of the duodenum, and it is usually solitary, means one. If there are multiple ulcers present, then we strongly think of Zollinger-Ellison syndrome. Second point, ulcers occurring distal to the duodenal bulb, means in the second part of the duodenum, third part, fourth part, or even in the jejunum, then this is a very strong evidence of Zollinger-Ellison syndrome. Third, strong family history of peptic ulcer disease. It may run as an autosomal dominant disorder. Okay, that is the one. Remember MEN syndrome, multiple endocrine neoplasia syndrome. So let me write it here for you. It may be a part of MEN syndrome. Remember, in MEN syndrome 1, there are 3 P's. Okay, 3 P's we say. 3P. Now 3P means pituitary, okay, parathyroid, and pancreas tumor. So this is a type of pancreatic tumor, gastrinoma. So it has a strong association, and it runs in the family as autosomal dominant disorder. Another important point, the peptic ulcer, okay, the peptic ulcer which is associated with diarrhea, steatorrhea, or weight loss. Now, many students are confused to give reasons here. Now, listen very carefully. This type of questions will be asked in the Viva exam, okay? Favorite questions from the examiner side. Now, there is high amount of acid production in the stomach because of the effect of gastrin. All that acid cannot be neutralized. So a lot of the acid will go go distally, not back, go distally towards the duodenum. Okay. Now, even with bicarbonate present in the duodenum, that high amount of acid cannot be neutralized. So what it is doing there? It is damaging or destroying those pancreatic enzymes which are coming from the pancreatic duct. Okay, everything is happening in second part of the duodenum. We all know that. So if we do not have those enzymes, what will happen? The food cannot be digested and absorbed properly. That results in diarrhea, steatorrhea, or weight loss. Steatorrhea is loss of fat in the stool, and if that continue for a longer time, the person will lose weight. Very important mechanism. Another one, peptic ulcer, which is not associated with H. pylori infection or NSAIDs. Now, there is no history. Okay, there is no history of NSAIDs, and there is no evidence of Helicobacter pylori infection. You cannot confirm it. Probably this may be caused by Zollinger-Ellison syndrome. So we need to confirm the gastrin level. Peptic ulcer, which is associated with hypercalcemia or renal stone. Another important point here. Okay, this is also the association of MEN syndrome. Remember, parathyroid disorder. In case of parathyroid disorder in MEN syndrome, okay, there is hyperparathyroidism, which can result in hypercalcemia. Hyperparathyroidism can result in hypercalcemia, and that hypercalcemia can lead to kidney stone. Now, ulcer, which is refractory to medical therapy, you have given acid peptic drug in a good dose. You have changed the drug also, but still the patient is not getting better. Probably there is a tumor, and only after surgery the tumor is going to disappear. And the last one, ulcer recurring even after surgery, because you have not removed that tumor which is causing ulcer. So all these are very, very strong evidence for the measurement of serum gastrin level to confirm a Zollinger-Ellison syndrome. One of the favorite question in the exam. Okay, so let's move on. Now in emergency department, okay, most of the young doctors work in emergency department under the guidance of seniors, of course. So if this type of patient come, what is your management there? Okay, it's a part of our investigation actually. Why I have included this under investigation is it is your job to make this patient ready for surgery, especially in case of perforation of the peptic ulcer. So these are all part of the investigation. Now see here, complete blood count has to be done. We must make sure if anemia is there or not. And anemia is there, what is the extent of anemia? Is it severe anemia, mild anemia, or moderate anemia? Serum electrolyte, blood urea, nitrogen, and creatinine level are a very useful test in this condition. Okay, a very useful test in this condition. Now why these all are a useful type of test? See here. Now electrolyte, BUN, and creatinine. Now, we can give different reason here, isn't it? I've already told you serum electrolyte are a very important part of investigation before surgery. They want to know what is the electrolyte level, what is the sodium level, what is potassium level. Okay, and one more reason, if gastric outlet obstruction has already occurred, this situation is associated with hypokalemia. So we need to make sure. BUN and creatinine. As a result of massive hemorrhage, there may be decreased blood flow towards the kidney, so that we should make sure whether the kidneys are functioning well or not. Okay. Do blood typing and cross matching, because this patient is going to need blood in case of severe hemorrhage. This is your job. Okay. Don't wait for the time. It should be ready by the time the surgeon need it. So we need to do it from the beginning. Activated partial thromboplastin time, prothrombin time, and international normalized ratio INR are indicated in patients with active bleeding and those on anticoagulants. We need to make sure this is no case of bleeding or clotting disorder before we send the patient to the surgery. Otherwise, there will be a lot of bleeding during the surgery and the surgeon cannot control it. And it is your, okay, you have not done it properly. So everyone will blame you for that. Amylase, lipase, and liver transaminase level should be done to rule out other differential diagnoses like amylase and lipase for pancreatitis and liver transaminase level for hepatitis. Okay. Patients who are younger than 55 years, see this, with no alarming feature should be referred for non-invasive test for Helicobacter pylori in the outpatient setting, because we do not usually think cancer in a very younger people. We think probably this is because of a peptic ulcer disease, maybe Helicobacter pylori or maybe NSAIDs. So to confirm that, we need to do test for H. pylori. And those tests are, let me repeat again, okay, rapid urease test, histopathological test, fecal antigen test. I can even go for antibody test. These are different things. Though it is a emergency department workup, which is done by the doctor which is present there, okay, it should be done before the surgery. So these are part of the investigation. Okay. Good morning, everyone. So let's start today's class. Today, first of all, I like to complete the discussion on peptic ulcer disease, some important part left behind from yesterday because of lack of time. Then I'll move on to the malabsorption topic. Now, yesterday we talked about what is peptic ulcer, what are the causes, what is pathophysiology, and then what is the diagnosis, how you make a reach to the diagnosis. So today we are going to talk about the treatment part. The treatment of peptic ulcer disease is divided into medical and surgical. We always start with medical. Then if medical treatment is ineffective, okay, or not successful, then we move on to the surgical one. Now, what are the medical treatments available? We use empirical anti-secretory therapy, empirical anti-secretory therapy, empirical triple therapy for Helicobacter pylori. Please mute, all of you, mute yourself. Endoscopy followed by appropriate therapy based on findings, and Helicobacter pylori serology followed by triple therapy for patients who are infected. Now, what does that mean? Sometimes the diagnosis is not yet confirmed. You have taken the good history and you are suspecting, yes, there is a high chance of peptic ulcer disease. So you use the drugs, that is called empirical therapy. Empirical, and many of the time we do that in clinical practice. So empirical anti-secretory therapy means H2 receptor blocker or PPI. Triple therapy, we are going to talk about that. This is given for Helicobacter pylori. Then if facilities are available, and everywhere this type of facilities available these days, endoscopy, you confirm the diagnosis and then give appropriate therapy. So these are important points. Now, endoscopy is required to document healing of gastric ulcer and to rule out gastric cancer. This usually is performed 6 to 8 weeks after the initial diagnosis of peptic ulcer disease. Now, what we are going to do here, after you do endoscopy, the disease is confirmed. You give the medicine. After that, you have to repeat the endoscopy once again, just to make sure the gastric ulcer is healing in time, okay, as well as duodenal ulcer. And sometimes it can complicate into gastric cancer, so that can be known again by uh, endoscopic examination. If you are doubtful, you can take biopsy and confirm it. In case of danger signs, okay, or danger symptoms or alarming symptom, we say, like dysphagia, recurrent vomiting, weight loss or bleeding, you do endoscopy quite early. Especially in the older patient, endoscopy is always done to rule out gastric cancer. Now, after knowing this principle, let's talk about what are the drugs. The two classes of acid suppressing medicines are currently in use. They are H2 receptor antagonist or blocker and PPI, that means proton pump inhibitors. Now, these are available in oral preparation and IV preparation, oral as well as IV. And the common examples, every student know this, you are studying this from the pharmacology lectures. Ranitidine, cimetidine, famotidine, nizatidine, all these are very commonly used drugs. And PPI, even more commonly used these days, omeprazole, pantoprazole, lansoprazole, rabiprazole, okay. So many new drugs are still coming. Now, what we do after the diagnosis of peptic ulcer disease, okay, you give this drug for a longer time, probably 6 to 8 weeks. Then you assess the patient, how the patient is responding, are those ulcers healing or not. So that always should be done. Now what we do for Helicobacter pylori, we give triple therapy, okay, we give triple therapy. Now what is that triple therapy all about? This is PPI based therapy, okay, that consists of 1 PPI, amoxicillin and clarithromycin for 7 to 14 days. Usually we give this for 14 days, okay. 14 days is more effective than the 7-day. So PPI, let's talk 1 omeprazole, amoxicillin and clarithromycin, these are the medicine. Amoxicillin should be replaced with metronidazole in penicillin allergic patient, because I can't give penicillin now or any related drug, so I need to use metronidazole in that case. So in penicillin allergic patient, I will go for PPI, metronidazole and clarithromycin. And these are the drug doses here. Omeprazole 20 milligram per oral twice a day, or you can use lansoprazole or any other PPI for that sake, plus clarithromycin 500 milligram BD again, and amoxicillin 1 gram per oral BD. So these are the doses of the medicine. So you can also prescribe these according to the need. If triple therapy is ineffective, okay, or failed, for example, then there is one more option which is called quadruple therapy. Quadruple, combination of 4 drugs, and they are given for 14 days. So what are those? Again 1 PPI, okay, 1 PPI or ranitidine, PPI or ranitidine, one of them, bismuth, metronidazole and tetracycline. So these are the 4 drugs, PPI or ranitidine 1, bismuth 2, metronidazole 3, tetracycline 4. They are given for 14 days. So this is called quadruple therapy. So you have to repeat this many times, because these are absolutely important things you should remember. Now we have done medical therapy or medical management. Now if these patients are not responding to medical therapy or medical therapy has failed, what else? What are those surgical treatment we are going to do? Let's talk about it. The indications for urgent surgery in case of peptic ulcer disease, okay, include failure to achieve hemostasis endoscopically. If that patient was bleeding from the peptic ulcer and you have tried to stop it with the help of endoscopy, and if that endoscopy also fails, we need to go for open surgery. recurrent bleeding despite endoscopic attempt at achieving hemostasis, okay, and perforation. All these are important points. Perforation is absolute indication for surgery. We have to go for laparotomy. Yesterday also I talked about this. Okay. Patient has to be prepared well, and then this patient should be taken to the operation room as soon as possible. Okay, laparotomy must be done, find out where is the perforation and go for the patching. At the same time, clean the whole peritoneal cavity. Now, additional surgical options for refractory or complicated peptic ulcer disease include vagotomy and pyloroplasty. One of the options. Vagotomy, the vagus nerve which is supplying the stomach, okay, is divided, is cut, because that vagus nerve stimulation is important for acid secretion. But at the same time, the vagus nerve is supplying other parts of the stomach for peristaltic movement also. It is also supplying the pyloric sphincter. Now, if we cut the trunk of the vagus nerve, we are in big trouble, because that pylorus or antrum is also not going to be functional. That's why along with vagotomy, you have to do pyloroplasty. Okay, you need to repair the pyloric sphincter. Vagotomy and antrectomy with gastroduodenal reconstruction, which are known as Billroth 1, or gastrojejunal reconstruction, which is known as Billroth 2. Now you have done vagotomy and you have done antrectomy. Now after that you have to do some reconstruction surgery to just to give continuity to the GI tract. Okay, this is the essential part, and these are called Billroth 1 or Billroth 2. And even after partial gastrectomy, we need to go for this reconstruction. Same Billroth 1, Billroth 2, and one more is called Roux-en-Y. Roux-en-Y. Okay, I'm going to explain about this one after other. And the last one, which is the best actually, if you can do, that is highly selective vagotomy. You will only divide those branches of the vagus nerve which are supplying the parietal cell. Okay, that's what we want in this type of cases, because these parietal cells are secreting a lot of acid. If we can, okay, cut the stimulation, the acid secretion will be less. So if a question is asked to you, please listen it carefully. If a question is asked which type of vagotomy is the best, you answer highly selective vagotomy, because it is not disturbing any other part of GI tract there. Now, one of the treatment option is gastric resection. After vagotomy, we go for gastric resection. Either one of them, okay? I'm not talking about both of them has to be done together. Either one of them, resection or vagotomy. Now, you may be a little bit confused here. So in which case gastric resection is done and in which case vagotomy is done. Now, for that, gastric ulcer is usually associated with a basal acid output, or in other words, the acid secretion is not that high in gastric gastric ulcer, I should say. So then why and how the ulcer is formed there, isn't it? That's the question again. Now remember, during the pathogenesis, we talked about two factors. One is increased aggressive force, second is decreased defensive force. So in case of gastric ulcer, the main problem is decrease in defense mechanism rather than increase in attacking forces. So the surgical treatment in case of gastric ulcer is gastric resection or gastrectomy. Whereas in duodenal ulcer, 100% of the time there is always increased acid secretion. So I need to go for vagotomy and some reconstructive surgery. Try to remember this. Sometimes your teacher, if you are doing very well in the exam, this type of questions are asked just to make sure how much concept you are having. Now, after doing gastric resection, we need to go for reconstructive surgery. Now see that this is gastric resection, the partial resection. Okay, let me use the highlighter pointer here. See here, this is partial gastric resection. This part of the stomach is removed. Now we need to give continuity here. That is called reconstructive surgery. Now what they have done, after we remove this part, they simply join the duodenal stump with the remaining part of the stomach. This is called Billroth 1. Now what is the problem of this Billroth 1? Okay, it is not considered a good type of reconstructive surgery because the bile is getting, bile is coming in the second part of the duodenum from the common bile duct. Now this bile can easily reflux back towards the stomach, and we all know this bile is very irritant substance. It can cause severe damage in this remaining part of the stomach. In a long run, it can also cause development of gastric cancer. So Billroth 1 is not preferred. What about Billroth 2 then? In Billroth 2, you do not connect this duodenal stump. Okay, see there, you connect jejunum. Okay, jejunum, a loop of the jejunum is connected there, so that there is no chance of reflux of the bile like Billroth 1, but still a bit of chance remains because this bile is flowing distally, and from here it can still go up. The chances are less than Billroth 1, much less actually, but chances exist. This is Billroth 2 reconstruction. Now the third one is called Roux-en-Y. This is the best. Okay, so these days the surgeon will always go for this type of reconstruction. See here, this is duodenum. Okay, duodenal stump. This part of the stomach is removed. This is first part of the duodenum or duodenal cap. This is second part of the duodenum, third part, and fourth part is here. Okay, now a loop of the jejunum is cut and it is reconstructed again towards the stomach and to the duodenum. So still we have this much of vertical segment here. So the bile has to pass this segment, then only it can reach the stomach. So the chances of bile reflux is very, very less in Roux-en-Y reconstruction. That's why it is the best. Now these are the pictures which tells us about vagotomy. Vagotomy. See there, these are the anterior division and posterior division of the vagus nerve. Okay, this is anterior division of vagus nerve. There is posterior division of the vagus nerve, and they are giving branches to all parts of the stomach as well as GI tract up to the middle part of the transverse colon. The vagus nerve is supplying till there. Now, there is ulcer here. Okay, it is shown here is an ulcer. Here, this ulcer is in the first part of the duodenum. Now they are going to do vagotomy. So there are different types of vagotomy here. One is called truncal vagotomy. So the main trunk of the vagus nerve is cut. Now after this, all these innervation, whatever the vagus nerve is doing, is also cut. This is a big problem now. Where is the peristaltic movement in the stomach now? Isn't it? And this pyloric sphincter also cannot function properly. That's why you need to go for pyloroplasty, okay, repair of the pyloric sphincter. This is the very important concept. If possible, highly selective vagotomy can be done, which are only supplying the parietal cells. Now, after doing this type of surgery, both vagotomy as well as gastric resection and reconstructive surgery, some complication will arise. So what are those? The first is called dumping. Okay, dumping. Now the meaning of dumping is there is a rapid gastric emptying which leads to distension of the proximal small intestine as the hypertonic contents draw fluid into the lumen. Let me make it easy for you. Now see here. So what are you doing there? Okay, you have made that stomach very small by doing gastric resection. Only a part of the stomach is left behind, so it doesn't have much volume inside. So whatever content is present inside the stomach, it can quickly go distally towards the duodenum or jejunum. Now these are all hypertonic contents. So they draw a lot of fluid into the lumen because of osmotic mechanism, which leads to abdominal discomfort and diarrhea. Abdominal discomfort and diarrhea. This is one of the important part of dumping syndrome. At the same time, the autonomic reflexes are activated and they release a range of GI hormone, okay, which can result in flushing, palpitation, sweating, tachycardia, and hypotension. So these all are features of dumping syndrome along with that. Now, we have already done the surgery, okay? So we cannot go back and reverse the mechanism. But what can we do then? We can, okay, advise the patient to avoid large meal with high carbohydrate content, because these are the osmotically active substances. So if the patient takes small meal, but time and again, the large meal should be divided into many small meal throughout the day. That really helps in case of dumping. Now, the second is bile reflux gastritis. In Billroth 1 reconstruction or even in Billroth 2 reconstruction, that is a chance. But in Roux-en-Y, there is no chance. Okay, so we go for Roux-en-Y type of reconstruction to prevent from bile reflux gastritis. This is an important point. Now, some other complication would be diarrhea and maldigestion. Now, the function of the stomach is cut off because we have removed the big part of the stomach. So there is poor mixing of food in the stomach. Poor mixing of the food. See here. Stomach content will be rapidly going distally. Okay, this is called rapid emptying. There is inadequate mixing now. Okay, and there is reduced small intestinal transit time because everything is going rapidly. Okay. The food should remain in our stomach for 2 to 3 hours, then only it should go down. But here that cannot happen. So everything is going fast. Okay, so resulting in less time for the digestion and absorption of the food. Now, there is one important thing going on. This is called bacterial overgrowth. Now remember that stump of the duodenum, okay, which is bypassed by the reconstruction surgery. Now in Roux-en-Y or even in Billroth 2, that stump of the duodenum is useless now. Okay, the food is not traveling through that. So if some part of our GI tract is like that, then there will be bacterial overgrowth, which may lead to malabsorption. So to control this type of diarrhea and maldigestion, okay, especially diarrhea because of maldigestion, we can prescribe antidiarrheal drug like codeine phosphate or loperamide. These are symptomatic therapy, only symptomatic, okay, because the mechanism is something else. Now, because of all these mechanisms, the person will lose weight, definitely, okay. The person cannot eat a large amount of food, small amount of food should be eaten, and at the same time, chronic diarrhea is happening, the person will lose weight. Now, some other complication would be anemia. Now, there are multiple mechanisms for anemia here. Iron deficiency anemia is the most common one. And we all know the mechanism of stomach regarding iron metabolism or iron absorption. Okay, the ferric form of iron is converted into ferrous form inside the stomach. The bigger food particles are broken down into a smaller food particle. Iron may be a content of that food. That is done by stomach. At the same time, vitamin B12, okay, deficiency is also very common because the intrinsic factor which is released by parietal cells, maybe that part of the stomach is sacrificed. Though some parietal cells are still there, we cannot remove all of them, but still that is a high chance. Okay, even folic acid deficiency can happen because of all these mechanisms. Now, in the remaining stump of the stomach, okay, ulceration can happen, chronic blood loss can occur, and that is another cause of iron deficiency anemia. So different mechanisms are there. Now, one of the dreadful complication of gastric resection is gastric cancer. In that remaining part of the stomach, okay, some cancerous change may happen, and the risk is highest in those with hypochlorhydria. Hypochlorhydria means decreased acid secretion. Duodenogastric reflux of bile. See that the reflux of bile is never good in the stomach. Smoking and Helicobacter pylori infection, which may be continuously occurring there. So all of these can lead to gastric cancer in the remaining part of the stomach.